Hi, welcome to the Spine MDT. So this video is about coccydynia, or pain around the coccyx. Before we go into it, please click subscribe so you can keep up to date with new videos posted on our YouTube channel on all things related to the spine, back pain and neck pain. Also on the link below you can visit the blog page where our videos also get posted, but there's also some written articles about conditions of the spine, ways to treat it, things that you might find helpful. So firstly, what is coccydynia? Well, it's pain that arises from the coccyx, which is the residual tailbone that has remained from our evolutionary ancestors. So there are different causes of pain that arise from this bone. The commonest is possibly trauma, so a really hard fall landing on the bum and causing a possible fracture or disruption of where this tailbone joins onto the bottom of the spine, the sacrum. That can often make the bone itself a bit loose and mobile, so sitting down on hard surfaces is what aggravates the pain. Rapid weight loss is a well-known factor that does it. Repetitive strain on the surrounding ligaments can do it, which is from repeated movements. A bit similar to what you see in tennis elbow, but around this area, of course. And it can also arise from the muscles of the pelvic floor where they attach to the coccyx, which we often see in women. Prolonged childbirth or labour, complicated labours, that can also be another cause of it. So if the pain has come on after trauma, so a hard fall on that region, or after childbirth, usually it will settle down on its own within a few weeks. During that time, simple analgesics or painkillers like paracetamol, ibuprofen can help, and you can buy special cushions where there's a gap in the area of the tailbone so you don't have any direct pressure on that area. The diagnosis is usually clinical. It's fairly obvious to most clinicians, so you don't always need x-rays, MRIs or scans or things like that. It can be made clinically. If it's prolonged and not really improving, then x-rays can help identify a fracture or an angulation. Sometimes dynamic x-rays between different positions that you sit in can demonstrate that fragment of the coccyx moves forwards and backwards. If you could demonstrate it being mobile, that can be helpful in confirming the diagnosis. Often an MRI scan can show what we call signal change within that region, where it can show active inflammation. I often save investigations for when the pain has been prolonged, it's gone on for more than a few weeks to a few months, and then we start to think about slightly more invasive measures we can use to treat it. So if the pain hasn't settled down and you can demonstrate on imaging the target of the pain being around the coccyx, or where it actually joins the sacrum of the spine, this bit of the spine here, one of the more invasive treatment options that can be considered is an injection of a steroid, literally in the midline between the buttocks, straight into that joint under x-ray guidance. Within that joint you can inject some local anaesthetic, a mixture of local anaesthetic and a steroid. Local anaesthetic works fairly quickly by numbing things up. Steroid itself can take a few days to a couple of weeks to kick in and take effect. But usually patients get a relatively good result out of that. Again, I don't dive in with this treatment as a first-line measure. Usually wait a few weeks with simple analgesics and position modification to see if that helps first. The reason we don't dive in with that as a first-line treatment is it's not without risk. The anal canal is very nearby, so this whole area has high level of bacteria in it. So doing an injection, anything invasive in this region, can actually cause infection in that area, which is quite difficult to treat. And for the same reason, surgery is an absolute last resort. Having a wound in this vicinity here does increase the risk of it being infected, so it's an absolute last resort. The indications for surgery are if all of the above treatments have completely failed. You also have to demonstrate that this segment here is mobile with with some dynamic x-rays, or there has been a clear injury to the coccyx with a fall rather than chronic repetitive strain, there's some evidence that those patients do gain some benefit. So overall, it's a condition that usually settles down with non-invasive measures. But at the spine MDT, if all of these measures have failed, we do have options. I work with a team of pain specialists who are very good at the injections, and it's extremely rare that surgery needs to be carried out. So I hope you found this video helpful. The goal of the spine MDT is to find the least invasive solution that gives you the longest lasting result. I'm able to do this by working with a big network team of all the professionals who manage spine problems. So spine surgeons, pain specialists, osteopaths, chiropractors, physiotherapists, all in one organisation working together to achieve that goal. If you have any questions, please call the number below or email us. Feel free to visit the website. And as mentioned earlier, please subscribe to the channel to keep up to date with videos that I post every week. Thank you.